Hi, everyone. Welcome to our March APIC Great Lakes virtual webinar. Um, I think we're going to get started just for time's sake. So let's hit our next slide. We want to just welcome you again. Myself, Kelsey, and Eileen, part of our education team. And then just a couple updates and reminders. So a new update that we have is for our APIC Great Lake Fall Conference. This year, we're going to actually be having it at the Kellogg Center at Michigan State University. And we do already have a date. That's October 15, which is a Thursday. So make sure that you save that date in your calendar. More details to come on that, but make sure you pass it on to anyone that you know might be interested in attending. And then just a couple other updates and reminders. If you have a job that you would like to see posted, we'll put it on our LinkedIn page for APIC Great Lakes. So just send it to this email here and we will get that posted. And then I think our last kind of reminder is, yes, if you want to go back and watch any of these webinars, they'll be posted on our APIC Great Lakes YouTube channel. So without further ado, today we have Erika and Ryan from our RESPTC team. And the presentation is just Regional Emerging Special Pathogen Treatment Center update. And I am going to let Ryan and Erika introduce themselves. So thank you guys for coming.
All right. Hi, everybody. Good afternoon. Thanks for having us. We're super excited to present to you all today. I am Erika Kurili. I am one of the Senior Infection Prevention Specialists at Corewell Health West. I started here in 2020, and I now work primarily as one of the infection prevention specialists that works with the RESPTC, which is the Regional Emerging Special Pathogen Treatment Center we have here at Butterworth Hospital in Grand Rapids. I also work with key improvements related to C. diff and construction as well. So, and Ryan?
Forgive me if I'm not great with Zoom. I'm a Teams guy. Good morning, or afternoon. My name is Ryan Thatcher. I am the clinical educator at Corewell Health for the RESPTC program, and I am also a consultant with NETEC, the National Emerging Special Pathogens Treatment and Education Center. About 20% of my time belongs to NETEC. And we're going to talk about, maybe we titled the slides a little different, HCID skills for hospital response. So this is normally a 7-hour training, and we're going to do a little bit shorter, like less than 45 minutes. So if it feels like there's more information that you would like, come to one of my trainings. So here is some great pictures of Erika and I, and a little bit about us. We already told you. Some learning objectives, which I feel like everybody cares a lot about. We'll just skip on through those. Okay, so the very first thing I like to start talking about is NSPS and a RESPTC overview. So you guys kind of are level set. Most people haven't heard about RESPTC or NSPS or NETEC. So it's nice to kind of give like a broad overview about that. So what is NSPS? NSPS is the National Special Pathogen System. It was started to be rolled out about 2 years ago from NETEC and the federal government. This is it's tiered much like the trauma system has been tiered in Michigan. This is different than SPRN, which is what Michigan used to have. The SPRN system is a tiered system in Michigan for special pathogen response. This is very similar to that, but the tiers are a little bit different, and this is a national system. Another thing that we want to talk about is what are high consequence infectious diseases. We often refer to them colloquially as special pathogens. These are diseases that have a high mortality rate, they're hard to treat, and they could spread very rapidly, or we have the fear they could spread very rapidly. Some of the examples, obviously, everybody's heard of Ebola. We haven't had a case of Ebola in the US since 2014, 2015 in the Ebola crisis in Africa. We repatriated 10 patients. There's also Lassa fever. We've had more cases of Lassa recently. Crimean Congo, it's probably the largest viral hemorrhagic fever. There's a lot of Crimean Congo throughout the world. Marburg disease. Then we have obviously the pox diseases and then some respiratory pathogens. I really think we should add COVID to this, but we have SARS and MERS. Getting back to the NSPS tiered system, there's level ones, level twos, threes, and fours. Level ones are the regional emerging special pathogen treatment centers. There are 13 of those throughout the country, with a combined 26 beds that are prepared at any time to care for a viral hemorrhagic fever patient within 8 hours of activation. Level twos are also required to be able to care for one viral hemorrhagic fever patient. The number of level twos is still a little in flux, but there was some grant funding that came out earlier this year, the end of last year, and about 55 facilities accepted that funding. And then there's another 20 or so throughout the country that didn't accept the funding but are maintaining their status as level twos. Level threes are meant to hold patients for up to 36 hours until they can get to a level two or a level one. And then everyone else is a level four if you're Joint Commission verified, because those new Joint Commission standards are the exact same standards required to be a level four. To look at those RESPTCs and where they are located, we are in Region 5, FEMA Region 5, and we are over here. I don't know if you can see my mouse. Can you see my mouse, Erika? Okay. And then we have a sister hospital, which is Minnesota, which is here. Minnesota's a medical center. You can see that there's a ton of RESPTCs along the East Coast, and then it gets quite sparse as you go towards the West Coast. That's not by design. It is how it is, but there's also most of the population in the country is on the East Coast, so it kind of makes sense. But you could see how it would be challenging to get to a RESPTC if you're not near one, like over here in this region would be hard because there's a mountain range here, and then the only closest one is Region 8. Okay, so any questions thus far? It's kind of very fast for me to go through this stuff.
None in the chat, Ryan.
Okay. So how many people are aware that we had a special pathogens exposure in Iowa, Illinois at the end of 2024? A couple people maybe? So in 2024, in October, an American citizen returned from Liberia to their home in Iowa. The patient was not symptomatic during travel. 8 days after their return, they went to the local emergency department with a headache, fever, and malaise. The symptoms did not trigger the travel screen, which we will talk a little bit about that later. And the patient ended up being cared for at 3 different healthcare facilities before they were diagnosed and died of Lassa fever. So if you don't know about Lassa fever, it is a virus. It's spread by a cute little mouse. See, I even put a little cute little mouse in the slides. And how it is spread is by inhaling or consuming the feces or urine, which you think that's kind of gross. Why would anybody eat the urine or feces of a mouse? But think about what people do for work. So if you're going to Africa and you're helping to work on construction or remodeling of structures, if anybody's ever done construction or remodeling, they know that you aerosolize lots of things, and dirty houses have mice and all of that. If you aerosolize that, or you eat a sandwich without washing your hands while you're working, it's not too hard to contaminate yourself with these types of viral particles. Lassa fever is harder to transmit human to human, thankfully, than some like Ebola or Marburg, but it still can happen. All in all, this individual was involved in 5 different healthcare facilities. There were 172 healthcare workers exposed without appropriate PPE, but there were 0 transmitted infections. Again, this was Lassa fever and not Ebola. If it would have been Ebola, there's a stronger possibility we would have had a lot more healthcare workers exposed and come up with symptoms. Okay. Any questions about any of that? And I can't see the chat.
No, none in the chat yet, either, Ryan.
Okay.
If anybody has questions, feel free to drop them in the chat. And Ryan and I, well, I'll monitor the chat. We can also answer any at the end too. All right. So kind of going in line with the Joint Commission comment that Ryan talked about earlier, we do have the 3 key principles that we are required by Joint Commission to have in place for our healthcare facilities when dealing with a patient, to be prepared to deal with a patient with a special pathogen. These are identify, isolate, and inform. So the first one here, identify, we want to be able to promptly identify these patients as they're coming into our facilities so that we can appropriately isolate and use the appropriate PPE for any of these cases. There's a couple ways that you can do this. Most people have this built into their travel screen. And there's there are a few resources that are going to be, we can link those when we send out the slides, for you to monitor any of the outbreaks that are happening around the world. And those outbreaks are actually triggering a lot of the already built EHR systems such as Cerner and EPIC. So next slide has the screenshot. This is actually an EPIC screenshot. I do not have a Cerner one if anybody is using Cerner, but this is kind of showing the electronic health record and how you are able to have a standard option. EPIC does have this standard build. You can also create a custom build to help with any of the infections if you do not have something addressing that you want to address. So for instance, there is a Galaxy EPIC tool that will alert every single time there is an CDC or WHO outbreak. That will automatically add that infection for those countries to EPIC, and they will automatically alert for a travel screen. But that does not help with situations such as our Iowa patient, where they traveled to an area where Lassa fever was endemic and nothing was built into EPIC. So this custom build option allows you to add in some of those endemic areas, regions for travel, so that you can kind of trigger when those patients have been traveling and then they're coming back with signs and symptoms of a special pathogen. There are a few resources for this as well. The Biothreats Emergence Analysis and Communications Network, also known as Beacon, does a great job of sending out anytime they have outbreaks or new cases, and that helps us as part of the RESPECT to be aware of those cases coming down the line as well. And next slide. So this is a screenshot of a possible setup that you can have when a patient does present. So when they fill out that travel screen, having this pop up, we call it the best practice advisory or our practice advisory. This will alert the team member in pretty bold lettering that they should probably think about putting this patient into the appropriate isolation immediately. So these are super helpful resource if you don't have one set up already. Make sure that you do have something set up in your EHR so that it is flagging immediately. Next slide. And then the second part of the identify, isolate, inform piece requires you to isolate that patient as quickly as possible. We do want to make sure that we place these patients in a private room with door. If you have a negative pressure room available, that is obviously preferred because we don't sometimes know what we're dealing with. And then we also want to ensure that our staff are donning the appropriate PPE for the infection. So lots of research will probably go into some of the PPE that we'll get into, but per the infection that you were concerned about, but making sure that they have PPE on is super crucial. You can also ask the patient to don a mask as well to help with transmission. Next slide. Some key considerations when you are isolating these patients is what do you do if you don't have one of those airborne isolation rooms available, such as some of our ambulatory locations obviously might not have the ductwork set up for the negative pressure. Just putting those patients into a room that has a door and labeling that room appropriately can significantly help with any transmission concerns as well. And then what if the patient arrived with a visitor? You'll want to make sure that you have a process in place for visitors. And then we'll talk about this in a little bit, but making sure you're working with your local health department if that patient did come with a visitor and what that is going to look like. And next slide. Once you've appropriately identified and isolated that you possibly have a patient with a high infectious disease, you actually want to inform somebody about that. So that could include us as infection preventionists, but it also will include other local authorities within your hospital setting. Sometimes leadership will be involved. Emergency management teams will probably like to be involved, facilities to ensure that your negative pressure room is appropriately working. And then a couple outside sources is the local and state public health departments. They're so crucial to the process that we have for our high consequence infectious diseases, as they help collaborate with all of the other parties as well. They will work with some of our CDC partners as well. As mentioned, timely reporting enables contact tracing and implementation of community protective measures as well. And we want to make sure we have access to those critical resources, as these patients do require a lot. One thing for this group to know about is that we do have the Great Lakes Healthcare Partnership. This group is actually, primary goal is to enhance the region's ability to respond to and recover from significant incidents and emergencies that impact healthcare delivery. So this is kind of like your emergency management team outside of your hospital, but they do work with all of the local EMS departments, first responders, and then a lot of the local health departments and the hospitals as well, to kind of collaborate with each other for all parties to be involved and help make that process a little smoother. Next slide. As we're all very well aware, the health department will obviously be involved with any of these instances, but they can, in partnership with the Great Lakes Healthcare Partnership, the health department will help with that transport and the ambulance service. They can actually help with getting a police transport as well, since we want to make sure that these patients are transported safely and that any stops that need to occur are done in a safe manner as well. They can help identify which hospitals have the capability to receive a patient if you are a level 4 and you need to transfer that patient to a 1 or a 2. As I mentioned earlier, you'll also have the ability to notify and contact some of those federal governments, such as the CDC, ASPR, the health department, and the state health departments as well. We're going to talk about this in a little bit, but testing and lab work is you have to be very careful with that, because your lab equipment can be contaminated. So we work with the state public health lab for any of our testing as well. And then, of course, connecting with the health department allows the connection with the local hospitals or the RESPECT and NETEC for additional support. Back to you, Ryan.
All right. So, personal protective equipment. And you see here on the slide, we have lots of people in PPE. This is not the general PPE that I recommend for level 3s and level 4s. This is kind of what we recommend for level 1s and level 2s a little bit. All the way to the right, you have Dr. Kevin Switek, which is one of our physicians on our team in what we call level 1 PPE. This is our high level PPE. He has a suit, a gown, and a capper on with 3 pairs of gloves and boot covers, really just to keep his feet combined. This is what our Minnesota counterparts wear as their level 1 or high level PPE. And then these are 3 of the level 2s in Illinois. These guys might be a level 4. So the number one thing I always ask people is, what is personal protective equipment really for? Why are we wearing personal protective equipment? And the answer that I want people to think about is PPE is to protect the patient from you and you from the patient, right? So sometimes we wear PPE to protect the patient, and sometimes we wear PPE to protect us from what the patient has. That's the basis of this. That's the only goal is to protect people. Through NETEC, we've come up with 3 different categories, and I'm still struggling to change our nomenclature at Corewell Health to this. I haven't worked very hard at it because it's a struggle for me in general. But those are NRP, dry, and wet. So NRP is your novel respiratory pathogen, and that's essentially COVID PPE. That covers everything that we wore during COVID for most places. That's covers your MERS, your novel influenzas. If there was a SARS, it would cover that. And then you have your VHF PPE, which is dry and wet. This is where I struggle because I am encouraging my ED staff to wear what is considered dry, but it's also for suspected, so I guess we can get there. The reason why I encourage that, though, is because of donning and doffing is the most challenging part with this PPE. And the training requirements to wear the wet PPE are much more significant. So let's blow into some PPE. We like to talk about head, neck, and eye coverings. Personally, if we're wearing an N95, I recommend the top corner here, this down here with an N95 and a shield. All of these work, but this protects your N95 from exposure if you get fluid splashed on you. For head and neck coverings, if you are going to encourage your team to wear head and neck coverings, my recommendation for you is to get a capper or a papper. If you're in an ensemble like this or this, it makes it very challenging for the team member who's going to be in PPE. These shrouds tend to be hard to get off, and the fitting around the face doesn't work as well depending on your face shape. And I feel like we have a lot more team members that get very heat sick very quickly in this ensemble. It is very, very warm without the papper or capper blowing on your head. A thing that I have to often talk about, not always am I speaking to infection preventionists, but I often have to talk about the difference between a mask and a respirator, and that an N95 is indeed a respirator because it filters particles. A lot of people don't understand that, especially lay people or newer nurses or techs. They just don't understand the difference between those two. And it's important that a respirator fits appropriately and you're fit tested for it. So that is something that you should be doing for all of your team members that are going to be in PPE that have to wear a respirator. When we talk about gloving in my realm, our team always wears 3 pairs of gloves. Some of the respects and level 2s are a 2-glove system. We went to a 3-glove system, and we treat the outer regular cuff much like the regular cuffed glove, much like you would treat gloves in the room. And then the extended cuff that's over our suit or over our level 3, level 4 impermeable gown, is we treat that like our skin. So 2 gloves is skin for us, and then that 3rd glove they can change in the room as much as possible. In this realm, we also sanitize gloves. I know that is taboo. It is very important that you are able to decrease the viral load on your PPE before you doff it so that you don't accidentally expose yourself. So as long as it's something that is killed by hand sanitizer, we recommend hand sanitizing. If your hands are grossly soiled, like let's say you had stool or emesis all over your gloves, we'd recommend you wipe them off with purple wipes or bleach wipes first, and then sanitize and then doff. I know that's different, but that is what the recommendation is from NETEC for doffing gloves. So for body torso protection, there's 2 different recommendations. I know this is looks like it's 5, but it's really 2 different recommendations, and they are either gowns or coveralls. For level 2 or that dry PPE, I recommend something with a gown because most team members that are not training quarterly can get in and out of a gown with a little bit of training. I mean, post-COVID, we all know that people have gotten a little laissez-faire with their doffing abilities and their donning abilities. But you don't want them to go into coveralls because they're so much more challenging to get out of without exposing themselves to their exterior of their coveralls, what they could have been exposed to stuff. Then generally if you're going to be in an environment where you're trying to protect your gown or your coverall, you're going to add an apron, a sleeved apron, or a cover gown over top of that to protect. We do it to protect our shroud. It's the number one reason why we wear a sleeved apron or a cover gown, depends on what is available at the time when we order. Then we have some shoe and boot covers. If you're in that gown, you really kind of need that knee-high boot cover for the dry. If you're in coveralls, we wear a shoe cover because it bunches up the foot of the coveralls. The coveralls are one size fits most, and the shoe size is size 15. And it doesn't help. It doesn't matter if you're in a small gown or small coveralls, the shoe size is still very large. So most people need that shoe covers just to contain it so that it's not a trip hazard. So putting it all together, everybody here has probably seen what NRP looks like, the novel respiratory. This is COVID PPE. I mean, I worked at several different hospitals during COVID. This is what almost everybody is wearing. In this picture, I'm assuming the yellow gown is actually a washable, like reusable level gown, unleveled or level 1 or 2 Amy gown. And obviously it's a cute little papper. Okay, going to the dry or the suspect. This is one of the recommendations we have. This is what I tell my team to wear. So it is that Amy level 4 gown of a shield, an N95, and boot covers with 2 or 3 pairs of gloves. Conversely, you can add the helmet. We have seen some people try to go away from boot covers, but what I've noticed is the team members who have trained to wear PPE for this really struggle with that. They don't want to not have boot covers on in this ensemble. Minnesota wears a gown, they don't have a coverall, and that they did a activation for a preliminary Lassa fever last year, and they downgraded to something like this, and their team really, really struggled not putting their boot covers on, and actually most of them still put on boot covers regardless, even though it wasn't recommended. This is the kind of PPE right here that I would call our level 1 at Corewell Health in the respect. I recommend this for only people who are training to don and doff quarterly. If that's the only thing I could hit home for everyone, don't rush out and buy suits unless you're going to train your staff to get in and out of them every quarter, because it is a lot of work. And even after multiple times getting in and out of these suits, we have team members that still struggle and I fear would expose themselves. It really takes a good 3 or 4 times before they start to feel pretty confident. And it's not like they have to do it from memory. They have someone reading a checklist to them, a donning coach or a doffing coach or a hot zone boss who is actually reading step by step what to do. And even then, after 2 hours in the suit, people that have been in and out still can struggle. It's also important to note that this ensemble costs somewhere around $150 per time. And then this one is something like $7. So if you're money conscious. Any questions about donning and doffing PPE? And if not, we can also have questions at the end.
None in the chat yet, Ryan.
Okay. Another thing that I want to talk about is breach management. In my realm of caring for patients, anytime we got down to the skin like this type of breach, we would recommend that they're required to put in an employee health. Every organization calls it something a little different, but to report to employee health that they had an exposure. We would consider a breach an exposure if it got down to skin or clothing. If they have feces or emesis on intact PPE, we don't consider that an exposure in our realm. So today, if you're taking care of a patient in Big Rapids at Corewell Health and you rip a glove, we don't call that an exposure in our regular units. But if it was on the special pathogens unit, the risk of exposure and what would happen to that staff member if they actually did contract, we want to track every single time that their skin is exposed or their clothing is exposed to the patient or their fluids. As for waste management, don't know. Cool. We really want you to think about this is not regular waste. If you have a potential Lassa fever patient or a potential Ebola patient, this waste has to be segregated. It is considered category A waste, and you have to have a special permit to transport it. It cannot go out in the regular waste. So our recommendation is you keep it sequestered until you have a confirmatory test. Here are the DOT requirements for special pathogens and special permits for category A. Currently, the only category A pathogens that have DOT approval for transport are Ebola, Lassa, and Marburg. Lassa is new since that Lassa fever outbreak in 2024. They updated the permit to include that. Not all waste handlers can transport this weight. They have to be specialty permitted and they have to agree to it. Also, it has a significant packing requirements. I don't remember if I left that in there. The specific packing requirements, generally, if you don't have an autoclave on your unit or in your hospital specifically for autoclaving trash or an incinerator, which I don't believe any hospitals in Michigan have an incinerator, then you would need to barrel your waste. Daniels uses a plastic 55-gallon drum. It has to be double lined. It has to be sprayed. The container has to be wrapped. All of the waste has to be monitored and then tracked. Those are very expensive. Each barrel is around $700. And you figure you're looking at over a dozen barrels a shift, a day, a 24-hour period for a respect unit. We would go through more than a dozen barrels a day. So it's a very, very intense. It's a lot of money. General waste, so patient care, like your regular waste would all go in there, including PPE and unused disposables. If it goes in the room, it's going out in trash. All of our linens, all of our sharps, all of our meds, all of our IV fluids all go out in the barrel. It said the recommendation from METEC is that you can inspect, clean, and disinfect mattresses, durable medical equipment, instrument trays, bed, stretcher, and intact wipeable surfaces. I would like everyone here to raise their hand if they would like to sleep on the Ebola bed. Please raise your hand. Okay. We would be disposing of the mattress for Corewell Health because that's gross. I mean, yeah. You can order an extra large waste removal container from Daniels or Stericycle so you can remove larger pieces of equipment like mattresses. Okay, see, we went through that really quick, Erika.
Very good, actually. All right.
So just so everyone knows, these email addresses, preferably the Corewell Health one, is the one if you would like any outreach, any standard work, any of that. And then this is the website to NETEC. Also, we have a new Corewell Health Regional Emerging Special Pathogens Treatment Center website, but I don't have that link with me right here. And that's able for everyone. Did I stop sharing my screen?
Yes, you did.
Okay.
Any questions? Oh, sorry. All right, Ryan, can you describe your process for room cleaning and who is responsible for it?
Yes. So for room cleaning, we have two different types of room cleaning. First is regular daily clean. So we admit a patient onto our unit, and we have a 12-bed unit. That 12-bed unit it's currently staffed and currently has patients on it. It gets completely evacuated, and we would admit one patient in those 12 rooms, or two patients if we had two viral hemorrhagic fever patients. Once the patient is admitted, the only people allowed on the unit are team members in the respect. So that means they had to have gone to quarterly training with me or my team, and they have to know how to don and doff PPE correctly. So daily regular cleaning gets handled by that team. There are no EVS personnel on that team. When it comes to after the patient is discharged and we do a terminal clean, we would still do all of the cleaning. And then we have a hydrogen peroxide fogger. So we would fog the room. Then after all of that is done, then EVS comes in to do a final cleaning of the space that's already cleaned before we put it back into use.
All right, looks like, yep. Rebecca put in the chat the EPA list Q, which is the newer list of disinfections that are approved for our emerging viral pathogens. So that is a phenomenal resource. We actually use that quite heavily here to determine what disinfectants we can use on the unit. Another question, are there any PPE donning and doffing videos available from NETEC or other organizations to assist smaller facilities with training their staff?
The answer to that is no. Yes, there are NETEC videos out there. They are actually from 2014, and they're on the CD. They're from the CDC. I reviewed them last week. They're not wrong. The old guidance is still valuable and useful. Some of it's a little bit overkill and not exactly what we're teaching to today. On our website, which I think Erika put in the chat, you can see the standard work, but I haven't figured out how to upload the donning and doffing videos yet. We do have them within Corewell Health in our LMS software for our team members to watch, but I haven't figured out how to make that into a viewable for the rest of the world. You can always reach out to us or NETEC and ask for assistance with your donning and doffing standard work, and I will always review that. If you reach out to NETEC, they're likely going to shift it back to me anyways. So it's just easier to reach out to us at Corewell Health, but some people feel better to reach out to NETEC. But we're your local NETEC people. So
I am going to drop in the chat, in addition to the Regional Emerging Special Pathogen Treatment Center page for Corewell Health West, I will also drop in the chat the NETEC resource library, which has a bunch of resources that NETEC work groups have pulled together as well. So if you want to look through that, there's lots of templates, lots of standard works, if you will, on there as well. And I don't have any other questions in the chat. Does anybody else have anything? Oh. One more question. How do you get healthcare workers to volunteer to work this unit, Ryan?
Hi, Doreen. Haven't seen you in a long time. I hope you're well. We at Corewell Health have an active team of over 70 members right now, and a team that's trying to become active of around 45 or 50 members. And then we have 23 members on our reserve team. So it's actually not been too challenging for us to find team members. We do pay our team members to attend training, but it's regular pay. They don't get any incentive for that. We have been really fortunate that because we added the respect, people want to be involved. And we have some really cool team members that have been really good at recruiting their friends. So I dig on my infection preventionists a little bit, but I have 6 on my team, and so they're probably all on this call. Erika's like, shut up, don't say anything bad.
They probably are.
But I think we have some really fun and engaging trainings. And the IPs, the IDs, and some of the other docs are really, really good at recruiting and getting the word out there. It's something interesting to be involved in for us. I think it's more challenging if you don't have a actual team, and most level threes and level fours are not going to have a team. Most of them are going to be training their emergency departments, um, maybe their OBs, maybe surgical services on donning and doffing. And I think my recommendation is going to be, I think my recommendation is going to be that you work with them to prepare them for anybody that flags positive, not necessarily the long-term care of a special pathogens patient. And really, it just becomes a requirement of those frontline staff in their role, not necessarily recruiting for a team. Erika, if you send a message to Kristen, she can send you the actual website.
Okay, thanks. And then one other question, Ryan. Other than the emergency department, which departments and units should be trained for continuity of precautions?
I think in the ideal state, and I say that because it's not what I've been able to achieve at Corewell Health yet. Ideal state, every single team member would be, from the CEO to the person that works in the basement that never sees a human. Every single person would be trained in identify, isolate, and inform. Even if it's just the very basic, how do you identify someone that's sick? How do you isolate them? And who do you inform? And I think that we could use that not just for special pathogens, but all cases. And we were pretty good about putting masks on patients when they were sick and asking them to mask. I think we've kind of gotten a little lax with that, but it's still pretty good. But there's so much more to that, especially for the larger facilities who have to have team or patients go through security before they come into the building. I really think that we expose those security guards to a lot. So my answer is everyone should be able to identify, isolate, and inform. And then for donning and doffing of high-level PPE, anybody who's going to care for patients should be able to don and doff high-level PPE. And that's kind of why I recommend the level 2 PPE that we use instead of suits, because it's essentially COVID PPE that's a little better, right? It's an AMI 4 level gown instead of your regular gown. You add boot covers, it's 2 pairs of gloves, but it's essentially what everybody's already wearing. So every clinical team member should be able to do that. At a bare minimum, I would say emergency department and obstetrics, because and probably urgent care, because they're most likely to be the first line people that are going to run into a person who has traveled outside the country and has been exposed to one of these diseases. It's not likely they're going to sign up for PT after getting back from Africa. It's not likely that they're going to show up at some other weird appointment before other contact with the health system. Possibly a doctor's office, but generally they're going to get sick, they're going to go to urgent care, or they're going to get sick and go to the ER, or they're going to come here and they're pregnant and they're going to end up in OB. Those are probably the 3 main points that I would really work on.
So Ryan, I do have another question for you. I know you encouraged folks to reach out to you if you do have questions, and you sort of teed us up at the beginning with a comment that about 20% of your time is spent as a need tech consultant. Can you talk a little bit more about kind of like what consultative or support services that you and your team offer to other facilities in the state, like our level 3s and our level 4s?
So in the state of Michigan, you may or may not have seen a lot of chatter from the healthcare coalitions. Almost all of the healthcare coalitions are hosting training for special pathogens between now and June. And that training is being put on by us. They have enlisted our help. We're free, so they didn't pay us. They have enlisted our help to give these trainings. They're 2-day trainings. The The slides from today are a significantly slimmed down part of the hospital day because it's a 7-hour day, with donning and doffing and patient wrapping. There's lots of skills involved as well. So that is one way to easily, like, if you pay attention, listen to the rumble of your region or reach out to your healthcare coalition, they are looking for people to fill those still. I know that we've only done 2 or 3 of the 8 regions so far, 7 regions. I think 6 or 7 are doing it. Then you can reach out and ask for input. We are very busy until the summer, until the end of July. But we will come on site and do a consultation with any level 3s, some level 4s. We will always look at standard work. We will look at we'll answer any questions that you have. It's legitimately why we're federally funded to be here, is to help not just our state, but Region 5. And we do a lot of that. Current state, we've been mostly only going on site for level 2s and some level 3s that are trying to become level 2s. That's not always the case. We do come on site occasionally for a level 3 or a level 4 if we can work it into our schedule and help them through that.
Yeah, that's really helpful. And I just asked because I know that you and your team do a phenomenal job with this program and are really a wealth of knowledge. So I just want to make sure that folks are aware that, this is something that if they're not familiar with, they know they can reach out. And Erika, I know you've been putting all sorts of links and emails in the chat, that folks can get a hold of you if they have more questions or, want some more information about what does this look like? How would we kind of work together on this? What kinds of things would you assess when you come on site? And, any of the potential benefits to them of going through this and how specifically you can be able to support them. So I appreciate you just kind of walking through that in more detail. And I know, like you plugged, the HCCs are all over this. So definitely encourage folks to continue to engage in that capacity too. I assume most of you already are, but if you're not, definitely another outlet to continue to kind of keep some of these trainings on your radar.
Yeah, I think the number one thing that I get asked about is standard work for donning and doffing. Almost everyone has it somewhere in a folder in the back of a filing cabinet from 2014, 2015. But a lot of people want it reviewed. Your vendors have changed. You plan to all wear suits, but now they're all disintegrating because no one has opened a suit in 10 years. A lot of PPE donning, doffing standard work.
Brian, I think you might have dropped. Can you still hear us?
I think he froze, so he's typing. He said his computer crashed. So okay, so yeah, any questions you guys have, the NETEC, with his work with NETEC, he can definitely work with a lot of any healthcare facility in the Region 5, FEMA Region 5. So that includes the entire state of Michigan. So we will drop all of I put a lot of links in the chat that are directly from the PowerPoint, and Ryan and the RESPECT team are more than happy to review any standard works that you do have related to special pathogens, even if it's from 2014 and you would just like us to give you pointers on how to update that, or what we have found through a lot of trial and errors that has worked and what has not worked for our team as well. And that includes, we do a lot of yes, we have the Regional Emerging Special Pathogen Treatment Center here, but we also, due to that, we have a lot of training that happens within the emergency departments and urgent cares as well. So making sure that if you have questions about those as well, we can certainly partner and help with that as well.
Perfect. Thanks, Erika. All right, so I know we have about 10 minutes left. Are there any other questions from the group? All right. Hearing none. Oh, a kudos, Erika, to you in the chat. So thank you for being here and for all the information. I will just take this opportunity to once again, Erika, thank you for being here and for sharing this information, and to Ryan too. I know we lost him, but I think this has been really helpful and informative. I see some more kudos in the chat here. Like we always do, and as Julie mentioned at the beginning, all of our recordings for our sessions will be posted on our YouTube channel. So if you need to catch up and rewatch something that you might have missed or want to share this with somebody else, you can certainly do that through our APIC Great Lakes YouTube page. Otherwise, we will continue to circulate and post slides afterwards. And please reach out to any of us at APIC Great Lakes if you have questions, comments, concerns, want to get a hold of Erika or Ryan, have suggestions for topics, anything you might need, please feel free to reach out. Otherwise, thank you for being here today, and have a great rest of your week.